Welcome again to another High Yield Medics session. This week we're doing a massive collab with How to OSCEs. How to OSCEs are a really good group of students at Bristol University as well. And they've basically been doing these amazing kind of one-to-one OSCE-based sessions. So I thought we'd get the group together, do a nice collab session on OSCE sessions, because at the end of the day, 50% of your marks will go down to OSCEs in a lot of universities. Because of the OSCE focus, our session will be a little bit different this week. So we won't do questions because it's not really the format of an OSCE. But what we'll do is some general pointers, how to prepare, some tips and things to do during the OSCEs, before the OSCEs, etc. And then we'll go into some specific high yield sessions, things like asthma with some COVID pointers, medication reviews, breaking bad news. And then for those of you that are in third year and haven't quite done specialist subjects like peds and contraception, we'll kind of give you a break so you can decide whether to leave or not. So a bit of a longer session, but we want to get as much really good high yield content in there as possible. As per usual, massive thank you to the MDU for sponsoring the event. And without further ado, we'll crack on. So I want to start this piece off by basically talking about how to prepare for the OSCEs. I think the biggest things here are get the basics kind of nailed down and correct. So you want to make sure that every minute counts, and you can be doing really niche bits, but typically in an OSCE exam, they'll test what they want from an F1 doctor or an F2 level doctor. Things like getting a basic neuro exam, really high yield, comes up a lot, but really nail down the basics and just get the basic level of information down. Second biggest point, working groups. It's a social examination. You're kind of talking the way through your exam, you're discussing it with the examiner, you're presenting yourself. And so working in groups, you're practicing that the whole way through. But on top of that, you're also getting ideas from that team that you're working with, just wherever possible, working groups, twos, working threes, or even if you haven't got someone with you, record yourself and you can kind of catch yourself out on certain habits that you form. Basically, just as much examination practice as possible and put yourself under the pressure of a group. With that, role play it. Try and get into the acting zone of things. I know as medics, we're not that dramatic always, but really try and get into the zone of it being a real patient. And then also mark each other quite harshly, kind of push each other to that higher level. Another big tip, ask around for year above, see what comes up quite common in your university, your school. Universities will often use these like similar questions from previous years because they know the mark schemes work for it. And they know the stations work as a test run. So it makes it a little bit easier for them. So ask what's happened before, what's kind of common in that school. Alongside that, procedures. We had IV drip at Bristol, and that's quite a common procedure to be done. We get given a CAPS logbook, which basically has all your different procedures you can go through. And realistically, you're going to get one of those. And they're hard to practice. You can go on Geeky Medics and things like that, but you need practice time. So talk to your CTS, talk to clinical skills nurses, anything like that. Ask if they can go through things with you in a room and go from practical procedure, set up an IV drip, to ophthalmoscopy, to basically any equipment you might need. Just having that ability to practice with the actual equipment really helps you on the day. So try and get the go with those. And although I said go to the basics and just focus on the basics, things like analogies stand out and look really, really good. I've recently just marked, kind of helped as an examiner in a year 3 mock OSCE. And a student used the analogy of a hose pipe to describe blood pressure, and just things like that to describe to your patient work really, really well, and just show that you've been thinking about things in these kind of non-medical jargon ways. So recommend those. And again, they'll come out in group works, that ways to explain things come out really nicely. Really good resource I used, Simple OSCE for your examinations, like your cranial nerve exams, abdo exams, things like that. It basically tells you, like Geeky Medics, exactly what you need to do. And then on top of that, it then has a mark scheme at the bottom where you can kind of tick off bits that you do or don't do. Again, do that in a group. You can record yourself, or you can actually use visualization. So with OSCEs, I think there's a big part of it is the mental prep, like any examination. And I kind of have 3 strategies that I wanted to share, and those are visualization, relaxation techniques. Obviously, you want to be nice and calm for these exams. And then there's something a bit more niche, but power posturing and a bit of... So visualization is used a lot. If you haven't heard about it before, it's kind of it's used a lot in elite sport, used a lot in interviews, prep, and there's a lot on kind of manifesting your future goals and all that on Google. But don't worry about the kind of extra stuff on there. Essentially, the basics behind it are: you're imagining yourself to be in the scenario you're going into, and that takes away the shock of it being the first time you do it. So imagine you're going to one OSCE for the first time ever, kind of your mock OSCE, and there's a bit of a shock factor in terms of something new that you've done, never done before. With visualization, and I've put some links in the presenter notes that I'll send out later so you can check it out. It is a really, really useful tool in terms of kind of repeating a practice examination in your mind, and you can do it in the first or third person. And you're basically just trying to think about what happens, the process you're going through, and imagine yourself going through that procedure. It works even better if you can add more senses. So if you can kind of work out what room you're going to be doing these exams in for your OSCEs, you can kind of imagine the room, look at it on Google, things like that. But in general, just think about a marker, a patient, and a kind of a generic medical room with some hand sanitizer on the side, and then just work yourself through these exams. There's a lot of research going behind it, actually preparing you really, really well, reducing stress. Relaxation techniques, you'll all have your own methods for when kind of stress levels are getting a little bit too high. Stress is obviously really useful, really important. It increases the rate at which you're working. But for an OSCE, you want to be calm, collected, going into that room. I use Headspace, Songs for Sleeping on Spotify, really good for calming down before kind of a long day revision, going to bed. Breathing exercises, there's all sorts out there, but now's a really good time to prepare for long-term life and just working on calming yourself down before big days, because you'll have lots of them going forward. And then power posturing is a bit more of a niche one, but there's some science in a TED talk that I've linked. A lot of people use this for interviews, and me and my friend Callum use this before our OSCEs. And essentially it's kind of getting into positions where you're open, you feel strong, you feel powerful. And there's been really good evidence prior to interviews, doing these kind of poses and getting kind of feeling comfortable, you come across more relaxed when you walk into the room, you come across more knowledgeable, things like that. And it can reduce cortisol levels, increase testosterone on a lower level, but it's all these extra 1%ers that you want, really. Again, put links in the present to view, so check them out later, but just really think about the kind of mental preparation, because it's useful for long-term learning as well. When I was marking these year 3 OSCEs, common one, obviously you're told wash your hands, especially with COVID, all the time. A lot of people put loads of hand gel on their hands and then trying to get gloves on, and it's just kind of they're then stuck with these gloves that aren't going on. Their hands are covered in this gel. It's a bit of a difficult start. So I always say just put a little bit on your hands. You're doing a hand gel every single station. It really adds up, and it's just if you've got excess, use your arms. Simple things like that to get gloves on just makes you look really smooth, really comfortable with where you are. Having a nice intro before you walk into the door. So I always went with, oh, hi there, how are you guys doing? Good afternoon. And just kind of getting a bit of a human touch with the examiner and the patient. At the end of the day, they're just there to do their job, and they're kind of happy to meet you, and they like a friendly face, just like anyone else. So bring out the personal side, have a nice introduction as you walk through the door, and then you can get into your jargon of, hello there, I'm X, I'm a student doctor, blah, 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 and your normal introduction. If you have any spare time, reread the question, really important one. There will be stations where you kind of run out, you run out of time. There will be stations where you have excess time, but make sure you have all the pointers of the question written down. If you do miss anything, you can always ask it later. It's essentially just a tick sheet. And if you haven't looked at mark schemes before, recommend just having a look. You're just looking to tick boxes, and there's no negative marking. Another really easy quick tip, and this is a huge one actually, is ask the patient, do they have any more questions? The patients basically have a scenario that they have to read beforehand, and they have a bit of artistic extra on the side of that. But realistically, they're going to stick to that pretty well. So if you ask, do you have any more questions, a couple of times in each one, they'll guide you down the right path, and they'll guide you towards the marks, which is really, really handy. So always ask any more questions in your ICE kind of layout. And then don't worry about getting something wrong. At the end of the day, you've got multiple OSCE stations, and it's only one tick box, e.g. say you're taking blood in an OSCE. If you don't actually get the blood and you've done all the correct procedures, you're still going to get pretty much all the marks, if not full marks. So don't reflect too badly on yourself. I'm sure you'll be fine. And final pointer on the day, don't lie. So it looks really, really professional when you ask a student, can you do this? And they say, say the patient asks a question, do you think this? If you don't know, just say, oh, I'm really sorry, I don't know. I can get leaflets for you. I can ask my reg. And that shows that you're a safe doctor, which at the end of the day, that's what they're looking for in an F1 student. So make sure you're safe. Big things, the examiners were in your shoes. They are very friendly, they are very relaxed, and they're giving you positive marking. There's no negative points. So it's a good environment to learn and a good environment to go through. I actually quite enjoyed my OSCEs, and I know quite a few people did. But just remember, the examiners are kind of like, say I was an examiner for a third-year OSCE. I'm just sat there. If anything, I'm a little bit bored. Kind of just want to get through these things and tick things off, but I'm just happy to be there. And it's actually a really nice environment once you go through. So take a bit of faith going into these exams. Feel confident in yourself, and know that it's not some big scary examiner marking you. I think that's really quite an interesting thing that I didn't realize until I became a marker. And just a take-home message on the general pointers: be confident, but also humble. So you basically just want to get a good-ish score in every single one. You don't have to smash any in particular. You just want to do pretty all right in all, and you'll get a very, very good score against your cohort. And that, I think, comes with confidence. So being relaxed, knowing your content, but also humble. You don't want to come across as cocky. You don't want to be unsafe. So if in doubt, say, oh, I'll ask my reg after this session, or oh, I'll ask XYZ. Trying to think of that, confident but humble. And it's a really nice way of coming across in an OSCE. I'm now going to hand over to the How to OSCE teams. So Holly's going to take you through medication review and counselling, and then the rest of their team will take you through the next few steps. As per usual, there's a Q&A section, there's a chat function. Use them for any questions you've got. We'll be here until the end of the session, and I'll probably stay on a little bit longer as well. But yeah, without further ado, I'll leave it to the How to OSCE team and Holly.
Hi everyone, like Freddie said, I'm Holly from the How to OSCEs team, and you'll meet the rest of us as we go along, give you sort of the best tips and advice for different high-yield OSCE stations. So I'll be starting off with medication review and counseling. Next slide. So with medication review, there's really three, or I guess two sections to it. First off, you need to go in, take your usual history, and then figure out what the drug-related problem is. So this could be kind of one of four things, I would say. Either you're not adequately treating the problem or the symptoms. Number two, maybe you're over-treating them, so giving them too many antihypertensives, and they're just having too many falls because of that. Number three, it could be polypharmacy, so there could just be a prescribing cascade, which we'll go over a little bit. Or the last one, the dosages are just wrong. Maybe they're too low or too high, or they're just not doing it. So that's kind of your first section. You need to figure out what's going on, and then do a really nice drug history. So ask them about compliance, and especially ask about critical medications, things like lithium or methotrexate, that they're doing things on time and also at the right times. Also, something to think about is medicine reconciliation. What this means is that when you are, as a patient, moving through from GP to discharge from a hospital to the pharmacy, all your medications stay the same and nothing is being altered without your knowledge. And that's something just to think about going forward in your practice. You need to ask them if they get anything over the counter. I know it's something we miss out in our usual history taking, but in a medication review, don't forget that. And in terms of anticoagulants, this is something I would specifically ask for in a medication review, regardless if they are taking one or not, or if it's on the list. Because if they are taking one and they just didn't write it down or want to see if you ask about it, it's a very serious problem, especially if it's a geriatrics patient who had a fall. This will determine if they get a CT scan or not, and typically they would definitely have to if they're on a blood thinner. So don't forget about asking about anticoagulants. They might also give you examination findings in the station. So for some of our mocks, we had AMTS and basic observations. This could be a lying and a standing BP. And then that kind of gave you an indication of what was going on. You could also get examination findings, like a neuro examination. And then if they're nice, the actor might give you a drug list, or a chart might be lingering around on the table. So just look around at all your props. And then from there, you can formulate what is going on and what your goal is to do with this issue and your action plan going forward. So I specifically put in geriatrics history just at the side because it's coming more common that in our medical schools they really emphasize on care of the elderly. At least they really do here in Bristol. So a really common thing is to do a 2-in-1 with a Jerry's and also medication review history. So typically it's a falls, you do your typical before, during, and after, and then you need to maybe just check what medications are on. Typically it's polypharmacy. And a very big one specifically to think about with Jerry's is the anticholinergic burden. A really common drug they'll kind of chuck onto the drug list to see if you see it is amitriptyline. So for example, they might have back pain and they're taking 20 mg of amitriptyline, but they're not on regular paracetamol. So that's something you could kind of pick out and say, right, well, we need to put you on regular paracetamol, stop your amitriptyline because it might be the cause of your falls, etc., etc. So that's kind of your first section of the station if this comes along. Next slide, please. So here are just some examples of prescribing cascades that you might see. I'm just putting it up here for you to read. I'm not going to go into detail, but typically what you would have to do is then change or remove some of the drugs at the very beginning so that you don't have all this polypharmacy going on. Next slide, please. So the second section of a medication review OSCE station that you should not skimp out on. So don't try to leave this to the last minute, even though you think that, you're trying to elicit the problem and it's doing you better to do that. It really isn't, because a lot of the marks is in the communication and explaining your action plan. So with your action plan, you need to explain what you think is going on to the patient, number one. And number two, it's really important that you discuss with the patient what needs to be done and ice them really hard early on. You need to ask them what's important to them and what would improve their quality of life. Because, for example, if there is a Jerry's patient who came in and you saw that they're on amitriptyline and oxybutynin and you're thinking, gosh, this is a lot of no drugs for the elderly, you might think to stop oxybutynin. But then to the patient, they will say, well, to me, going to the bathroom every 20 minutes is the worst thing ever in my life. The oxybutynin is really helping me. So you need to work together with the patient and their ice and all that in order to decide what you're going to do with your action plan going forward. Typically, a phrase that I would suggest you guys use is to say, okay, so we're going to do a trial without blank, whatever medication it is. Because if you say, I'm going to stop this medication, patients might think that you're not treating them anymore and they get worried and anxious. So it's just a nice phrase to use just generally in your consultations in GP and in hospital. And it just sounds more gentle in OSCEs as well. And then importantly, in a medication review, you're always going to organize a follow-up. So obviously you're acting, but just say, okay, well, I'm going to organize a follow-up in a couple weeks or a month's time, plus minus investigations you have to do to check if the medication is working. So that's sort of everything with a medication review in a nutshell. But just think about this pro forma of what is the drug-related problem, what are you going to do about it, and then follow up. So hopefully that simplifies things for you for medication review. Next slide, please. So now medication counseling. This is quite an easy one because the structure, as you can see, is on the left. You can screenshot this, do whatever you want. This is the structure that I would apply to every medication you're going to counsel a patient on. Key things, you're going to ice them about the medication early on, ask them what they know. This will enable you to answer any fears or any things that might be on their mind. Take a very quick focused history just to see why they're starting on it. And then don't ever forget about following up once again. Like with any sort of medication station, you need to follow up on them in a couple weeks' time to see if the medication is working. And then a very nice one here is to always chuck in a leaflet and say, here's some more information if I haven't covered my bases. And then in a station like this with counseling, another important communication station is communication advice is to chunk and check throughout. This is something that will gain you kind of a good mark with fluency, and it looks nice, and it makes sure that you are kind of not just spouting facts at the patient and actually taking into consideration what they're feeling about everything going on. Another aspect to a medication counseling station is that they might have what I call patient comebacks. So usually it's simple things like appeasing their worries about, particular side effects or pertinent to statins. It's things that they've read in the news or things that they think you're working with a pharmaceutical company, you're just trying to make money. So just make sure that you have those, kind of one-liner, two-liner kind of responses to those sort of kind of anxious, worries and fears. And if relevant, you can also kind of sneak in a little bit of smoking cessation advice if it's relevant to the station, like if it's post-MI and you're starting them on, I don't know, an ACE inhibitor, for example, and then you can always say, well, if you'd like to stop smoking, it would really help your heart. We can talk about it in another consultation if you're interested. So that's something that would be that could come up in a medication counseling, but pretty basic. And someone's asked, how do you offer a leaflet without miming or being overly dramatic? Well, I don't think it's very easy to be overly dramatic to offer a leaflet. I think just say it as you would normally. So for example, I would say, okay, so if you have any questions, let me know. We can always organize another consultation. In the meantime, here's some leaflets for you to read and take home. If you have any questions, let me know. And that's basically how I would summarize it and put in that whole leaflet sentence. So those are kind of the medication stations in a nutshell. And I will then go on to the next slide, which will show just sort of potential counseling stations on the medications to be aware of. I've bolded the ones that I think are a little bit more important, but then again, it depends on your school's curriculum and anything that might come up. But just be aware that these are some of them. This is not a full list, but anything more than this is a bit more rogue. So there you go. So now I'll hand over to Hannah, who will go over asthma review.
Hi guys, yeah, so my name's Hannah from How to OSCEs as well. So we've just got kind of a few more stations to go through that are quite high yield and might come up in your OSCE. So first one being asthma. So next slide. So this one's really common because it can be applicable to paediatrics, adults, and also GP, which are all of the kind of common categories that they try and have stations from. And you can also use this similar framework for other kind of review appointments, but I am focusing on asthma here. So first thing to think about is, why have they actually come for a review? Did they have a recent admission to hospital, or have they kind of just been struggling with symptoms? And this might kind of, the setting that you're actually in will help with this. So like, are they at the GP or are they in secondary care? So first thing to do, establish their symptoms and how well controlled they are. So you want to be thinking about the chronic symptoms. So thinking about specifically how they impact their daily function. Are they able to actually do everything that they need to do in a day? How often are the symptoms occurring? Is it just a couple of times a week, or is it happening like every hour? And kind of looking at the frequency of the blue inhaler use, which will kind of really help you have more of an idea. And also, have they had any asthma attacks, which I guess links in more with the acute things. So then you want to ask about what these acute attacks have been like. Are there any obvious triggers, and what kind of symptoms are they having when they happen, and how long do they last, and things like that. In asthma, it's good to ask about whether they've had any acute admissions recently or ever, and have they ever been in ITU, and then establishing the frequency of these asthma attacks, because then that leads you on to the current management and thinking about whether or not this is sufficient, although it's really important to actually think about compliance and also inhaler technique, because they might be on a sufficient dose of things, but they're actually just not taking it because they haven't realised that they're supposed to take their preventer every day. They think it's just when they're having symptoms, or they're not using their inhaler properly. And I think especially at Bristol, they seem to really like you suggesting the use of a spacer. So that's probably a good thing to do. And then also just asking if they have an asthma action plan. Everyone who has asthma should have one. So if they don't have one, then you should make one for them. And if they do, then consider whether or not it needs to be updated. So next slide. So then that's kind of, I guess, the history of presenting complaint. And then moving on to kind of almost like past medical history. So thinking about the asthma history, thinking when it started, has it been getting worse or better with age? Do they have any family history of asthma or other atopic conditions? And then really just, if you haven't already, asking about previous hospital or ITU admissions with asthma, and then other medical conditions. And then it's always useful to think about whether or not anything in their lifestyle might be triggering it. So examples can be things like smoking, which you might then want to kind of counsel a little bit on whether or not they want to cut down. Other things can be things like pets and things, like they might not realise that their pets trigger their asthma. And it's always really important with kind of every review of a condition is to think about follow-up, and well, in every OSCE, it's always good to give out a leaflet if it's applicable. So there we go. So that's most of the key things for asthma. So we'll move on to counselling about a diagnosis. So this could be about any diagnosis, just kind of a framework to work through. So next slide, please. So kind of split it into sort of an overall framework, which is here. So this might be for someone who's had a new diagnosis or something, or kind of recent diagnosis, or it could be as part of a review appointment. And obviously you'll kind of tweak the amount of explanation depending on what situation you're in. You start with taking a brief history, and especially in an OSCE, I'd emphasise that this should be 1 to 2 minutes maximum. You want to establish what their symptoms are, how it's affecting them, and just try and do it as snappy as possible. And then move on to assessing the understanding of the patient about whether or not they understand what they've got. So let's just think that we're talking about asthma. Do they know what asthma is, basically? And just sort of establish what they actually want to know about their condition. And also then you can move on to ICE. So do they have any concerns about it? Because this means you can really target the explanation that you're about to give them to make sure that you're addressing any concerns that they have. And it also ticks another box on the mark scheme. So in terms of explanation, here's just a little framework that you can use for explaining a disease. So essentially, it's kind of self-explanatory, thinking about what's normal, what the disease is, and how that changes their anatomy or physiology. Maybe look a little bit about the cause and any kind of complications that they might end up having, and then gear that towards management, which will kind of lead you into the end of the consultation and lead you onto your summary. So it's just a little framework. Okay, and then the final station that I've got for you is breaking bad news. So really common station. I've just kind of got a few general tips, and I just draw your attention to the bottom kind of example stations, which just, I really wanted to emphasize that breaking bad news is not always going to be something really obvious. It might not be telling someone they have cancer. It could be the diagnosis of an SDI, the diagnosis of any chronic condition, like basically just any news that someone doesn't want to hear. So I think recognizing that a station you can use this breaking bad news framework is quite useful, because you might read things say, oh, well, you need to tell this person they've got diabetes, and you might not necessarily consider that to be breaking bad news, but just kind of, think of that. So in terms of general tips, introduction is really important. Obviously, you're going to really have to get rapport with this patient. So make sure they know who you are, make sure you know who they are, and kind of explain why you're there, and get consent to discuss that. And you may want to touch on confidentiality as well. I think it's really good to be specific and clear with your, with your explanation or with your consultation, and to try and avoid euphemisms, because it can sometimes be very unclear, and then patients can get confused about whether or not you're telling them, you know, am I going to die, like that kind of thing. I think sometimes it's worth saying the words like cancer, for example. Like, you shouldn't always avoid it. And then another thing is avoid medical jargon. You really want to keeping your words simple, because especially if you're telling someone bad news, they're not really going to be wanting to translate everything you're saying to them. Okay, so then I'm going to move on to spikes, which I'm sure everybody has heard of, but I thought it'd be useful to just quickly run through it as just a framework for breaking bad news to people. So on to the next slide. So the S stands for setting. So sometimes a bit tricky to do in an OSCE, but it's really important you've got a quiet and private room. So, I mean, some people had suggested maybe you say at the start, oh, so I'm just going to bring you into this side room, or, you know, something to kind of illustrate to the examiner that you have thought about this. And there might be tissues on the table, for example. A general tip for OSCEs is if there's any props on the table, try and use them. So yeah, for example, in this, there might be tissues. Okay, and then on to perception. So establish what the patient or the relative knows so far. Oh, and actually a point on that is if there are relatives in the room, which there probably won't be in an OSCE, make sure that you ask the patient whether they're happy for them to be present, because they might not want that. Yeah, so establish what the patient knows, and kind of think about what their current emotional state is, because they might have no idea that they're about to receive bad news, but they also might have an idea, they might be really nervous, and just try and kind of, because it can help guide your how gentle you are. And then discussing the sequence of events that have led to this moment. So they might have had a scan, they might have had a biopsy, can kind of help you sort of naturally lead you towards the bad news rather than just suddenly saying it. And then sometimes asking about any symptoms that they might have had that kind of led to all of these things can also be a good kind of segue towards the bad news. So on to the next slide. So the I stands for invitation, which is just basically just ask them whether or not they actually want the results, because they might not want them, although in an OSCE they will. So, so knowledge, so this is kind of, I guess, the key bit really. This is where you're actually going to tell them. So key things I've put in bold: definitely give a warning shot. So, you know, say something like, okay, so I'm afraid I've got some bad news, or, you know, you'll find a phrase that works for you. And then being aware that after you've said this, it's going to be really hard for them to actually take everything in. So just keep everything in small chunks and keep checking that they're on the same page with you, and allow there to be silence and large pauses, because the patient needs to digest what you've told them, because they might not have been expecting it. And even if they were expecting it, then you know, they need time to process it. And then, yeah, just I've put a couple of phrases in there that you can kind of decide whether or not you like. So just using simple language, again, as I've mentioned before, and, you know, saying like empathetic phrases like, I'm sorry that I've had to give you this news today, and things like that, just as you feel it's appropriate. Okay. So then on to emotions. So kind of recognize and respond to any of these emotions. At this point is basically just be nice to them and acknowledge how they feel and validate it. And then the key thing really is just to be really honest about the prognosis. Like if they ask you, like, am I going to die? And you know, yes, they are going to die, then you kind of, I mean, obviously you can be careful about how you say it, but you've got to be honest, and don't give any false hope. And then, yeah, if you can't answer any of the questions, then make sure that they're going to be referred to a specialist who is going to be able to address any of their concerns. And it can be important to acknowledge that it's frustrating for them to have unanswered questions, and that you're working with the team to kind of make sure that they get the information they need as soon as they can. Okay. And then finally, on to kind of strategy and summary, basically just talking about the next steps, reassuring them again, and don't rush them to make any decisions about treatment unless it is an emergency. But a lot of the time there is at least a little bit of time that you can sort of almost leave them in the room, say, oh, I'll just leave you here, you can just use this room, maybe get them a cup of tea, and then say, like, I'll be on the ward if you have any questions, or I'll come back and check on you in half an hour or something like that. And then, yeah, make sure they also understand what you've said as well, and see if they've got any questions. And provide a summary. So those are kind of some of the key tips for that. So moving on to data interpretation, Theodora.
Hi everyone. So this is going to be our last section that also kind of involves third years. Next slide, please. Fine. So data interpretation is quite broad. So there's things that it goes from X-rays to ABGs, spirometry. So my advice would be just start with the basics just for everything. So the way I like to divide this is the patient and then whatever data you're interpreting. So in terms of the patient, I always go for full name, date of birth, and hospital number. And then for the data, always check the date and the time it was taken or done. If it's an X-ray we're talking about, always ask for other views and previous films. So it will also help you find whatever is wrong with it. And it always, whenever you're looking at an X-ray, one view is never enough. So that would be part of your marking scheme. I sometimes also feel a bit lost when looking at x-rays, especially bones, and maybe the pathology is not very obvious. So what I would suggest is literally just using your mouse or just whatever's a pen or whatever's available, and just outlining the bones and literally just checking whether everything looks symmetric, whether everything looks okay, that there are no cracks or any other abnormalities. If it's an ECG, I would always ask for another one, like a previous one, to compare it with. Again, the pathology might not be very obvious, so having a normal one or just like a previous one to see whether the abnormality is stable or not, or whether there's something new, will always help. And then also finding a structure that works for you. So I think, as Freddie mentioned earlier, there's no right way of doing things usually. So there's tick boxes that basically you need to tick, but there's no specific order in which you need to do this. So what I do usually with x-rays and things like that is I first say what the pathology is, if it's something really obvious and I can see it straight away, and then I just move on to everything else after that. However, if you're not sure of what's going on, you can literally just start from top to bottom. So for example, if it's an x-ray, do your A, B, C, D, E, and then know your anatomy, which I know is very annoying, but if you don't know what things look like or where things should be, you won't really be able to notice if there's something wrong. And then for things like ABG, spirometry, etc., I think it's quite important to explain the values and the ranges. So for example, in spirometry, if you're looking at the forced vital capacity and the FEV1, just have a brief sentence, define it very quickly, just so that the patient knows what's going on. So I would say, we look at 3 values, the FVC, which is blah, 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 the FEV1 and the ratio between the two, and your values are whatever they are, and that means whatever it means. And I think that would score you points and also will help the patient understand whatever is going on. Again, if you're not sure about ranges or anything else, you have to be safe. Don't make anything up. I think everyone else has emphasized quite a bit on this, but always say you'll check the guidelines, because OSCEs are basically about making sure you're being safe. So making up things that could actually make you fail the station. So if you're not sure, just say you'll check. And the final thing is, these stations are not usually just data interpretation, so they will always come with something else. That could be either taking a focused history or coming up with a management plan. So we often get asked about what a focused history entails. The way I like to think about it is what their current symptoms are, the risk factors, and the red flags of whatever system is affected. So if it's a RESP station with an ABG or a spirometry, just ask about their symptoms, usually shortness of breath and cough, get a bit of information about those, then risk factors such as smoking, recent travel, things like that, and then red flags. Are they coughing up blood? Are they losing weight? Do they have any fevers? Are they waking up at night? That sort of thing. And then if it's coming up with a management plan, again, you don't have to go into a lot of detail if you're not sure, but always offer patient leaflet forms and then also follow-up appointment. And then if they are in pain, never forget to ask about analgesia or whether the pain is under control, whether they need anything else to control that. And that's basically everything on data interpretation. I know it's quite a lot, and I wanted to just add some key points of everything. But the other thing would be to just practice. And the more you see, the better it is, even like just normal and abnormal x-rays or ECGs or any data. Next slide, please. So this is basically everything that also involves third years. So now we're going to move on and talk about pediatrics and contraception. So these are things that you will also encounter in GP and other environments. If you're more than welcome to stay for those 2 topics as well. But if not, here's a QR code or feedback form. And our sessions will be continued next year as well on Mondays. So if you follow us on Facebook, you'll be up to date with when we'll start these things. So yeah. And then if you've got any questions, feel free to email us as well. Fine. So now moving on to contraception, the topic that everyone hates. Next slide, please. So I've just gathered here some top tips, like general tips, and then I'll move on to specific contraception stations. So the first thing is, especially for counseling stations, again, you need to learn all the options. So you need to be aware of what's available out there in order to be able to explain that to patients. And this is quite annoying, but you have to find the easiest way for you to memorize them. So you can divide them in hormonal and non-hormonal, or barrier versus combined versus progesterone only. You can do the long-acting ones, whatever works best for you. There's 1,000 ways. I really like Teach Me Ops on Gynae for this. I think they explain them quite well. So there's many options out there, many resources where you can see different ways of organizing them. But yeah, and then pay special attention to contraindications and cautions. So I would do this basically as you would do in any other station, asking about risk factors or red flags for something. Do the same thing with contraception. So just learn the main contraindications, say for the combined pill, and just ask about migraine, breast cancer, and things like that. Just have like a list of screening questions, and just say, I'm not going to run through a list of questions just to make sure that we can actually give you this form of contraception, and just go for it. And then with emergency contraception, there's a few, there's 3 key questions I think you should always ask. Basically, one was their unprotected sexual intercourse, so that the timing is very important, because that will determine which option you go for. Then what stage of their menstrual cycle they are on. So sometimes whether whether it's after ovulation or before ovulation, again, can determine which method you would go for. And then what normal contraception methods do they use? And this is basically a way of making sure they are taking them right, or whether they've just forgotten to take them, or for example, if they're on the pill and they've not used barrier contraception, but they are taking the pill, then that means they are protected from a pregnancy point of view, but maybe not for STIs. So just, I think those are the 3 main things. And then in terms of follow-up, always offer a pregnancy test after 3 weeks, even if they've experienced bleeding and they've had emergency contraception, always say do a pregnancy test 3 weeks after. And then also offer an STI check. It's always a good opportunity to introduce that. You never know how long it's been since they had the last one, and it's a good kind of intervention, if you want to say that. And then moving on to minors, it's important that you know the legal age for sex in the UK. So usually any child that's below the age of 13 is not deemed capable of consenting for sex. So you should involve child services immediately. And another question that I like to ask, both for minors and adults actually, is whether the intercourse was consensual. Then in terms of postpartum contraception, the main thing I would say is remember asking about breastfeeding. You can use lactational amenorrhea only if they are fully breastfeeding. If there's a mix between feeds and breastfeeding, then it doesn't work. So it's very important to know that. And also the exact date of delivery. So there are certain things like, for example, coils that you can't use, or you need to wait 4 weeks to use them, or insert them. So it's quite important to know the exact dates if you're going to book them in for a coil insertion and things like that. Then get eyes early on. I think this is very important for any station, but I would say particularly contraception. There's so many options out there that you can't go through all of them in just 10 minutes. So the actors will have, as part of their brief, which methods they want you to cover. So if you ask them, have you heard of a particular one? Are you interested in a particular one early on? Or is there anything you're concerned about? Then they'll kind of hint that, and then you can tailor your station and how you go about it, depending on that. And then again, previous contraception. So this comes to bad experiences. So this is related to ICE as well. So if they've had bad experiences with some methods, this needs to be taken into account. And again, it's an opportunity to offer contraception if they are not on any contraception method, and also check if they are taking it or using it correctly. And again, if you're not sure about something, don't make it up. Contraception is quite a heavy topic, so it's quite difficult to remember everything, especially when you're under stress. So just say you'll check the UK MEC guidelines or check with your senior, but just make sure you don't make anything up. Okay, next slide, please. Fine, so I'm not going to go through this into too much detail because we're going to send you the slides, but just some common ones, some common stations that you can get are, again, emergency contraception. So these are some of the key points. Mainly ask about when the sexual intercourse was, and just tell them about the 3 main options and the pros and cons of each one, and then never forget about the follow-up. So pregnancy test in 3 weeks and STI screen. And then for the missed pill, again, just know the different options, the different kind of rules depending on the option. Next slide, please. So then contraception after 40. So again, this is one of those things you kind of need to memorize. So women do still need contraception even after the age of 40. And then depending on which contraception method they are on, they will have to stop it at one stage or another. So we'll send you these things, but basically it's on PASMED, it's on the UK MEC guidelines and on ICE. And again, it's one of those things I'm afraid you just need to memorize. And then contraception under 16, again, just know that 13, if they are less than 13, you need to involve child services. And then young patients are also advised to have STI tests after 2 and 12 weeks if they've had an unprotected sexual intercourse. So that's slightly different from adults. Next one, please. And finally, postpartum contraception. So again, there's different options. There's 4 main options, and women usually need contraception after day 21. And if they are having a C-section, the difference is they could have a coil inserted within 48 hours. Childbirth in general, but if it's a C-section, you can do that during the C-section. So if it's early and if it's before they've given birth, you can mention this, that they can get a coil within 48 hours of giving birth. Otherwise, just know the other 4 options and kind of when they can start each one of them, if that makes sense, and never forget about breastfeeding. And yeah, I think that's it for contraception. Sorry, that was quite a lot, but we're now going to move on to the pediatric stations with Rosie.
Thank you, Theodora, for this. Hi, everyone. I'm Rosie. Just going to quickly go through the general structure of a pediatric station, and then we'll go on to an example of a station that you could get that I thought is not it doesn't follow the normal structure of a pediatric history, but you'll see what I mean. So next slide, thank you. In general, with a pediatric station, it should follow pretty much the same structure that you would with an adult history, except for there are different bits that you need to remember to ask in every section of the history. So to start off with, whoever you're presented with, of course, like ask who the child is and ask who's coming in with the child, and the relation of the person that's coming in with the child. And then if the child is old enough for you to talk to them, try and conversate with them. If not, then just mainly you will kind of get the hint from the parent or whoever they're coming in with that you will need to take the history from the parent. For OSCE's sake, I highly doubt they'll actually get an actual child, but maybe they will, I don't know. But also remember to kind of pick up on if the parent is talking over the child and not giving them time to, answer your question, then think, is there a safeguarding problem happening here? But anyways, so in terms of the presenting complaint and history presenting complaint, use the same structure you would with any other history. So Socrates for pain or otherwise. So kind of Socrates is good in general to get a timeline of things and how things have been progressing, etc. I personally like to use to kind of establish bias early on, because sometimes they will give you hints in the beginning of the history, like, oh, well, their sibling has been like ill over the past week and I'm just worried they have the same thing, type of thing. So that already gave you information that someone at home is ill. So it's a good place to kind of just ask it in the beginning. And then review of systems is very important, because with children, they might not, like, there are certain symptoms that they might not have, like present with or complain of like chest pain or certain symptoms that we do get with adults, but kind of the general, their appearance and how they've been, is good to kind of understand when asking review of systems. So cardiovascular, respiratory, you can ask like if they've noticed like their breathing has been changing, or any sort of, if the mom or the parent that's coming in with them is worried about, you know, an increased work of breathing, or like watching for signs of like respiratory distress, that kind of thing. But also remember to ask about rashes, if they've been just generally, you know, themselves, or have they noticed their behavior has changed, you know, a bit groggy and not themselves, and that applies for any age, of course. And then ask about food and eating and drinking. So remember with babies to ask if they're breastfed or bottle fed, and also remember to ask if they're latching on well, because that's something that, you know, if a baby's presenting with failure to thrive or weight loss, things like that, it could be that they're just not eating well rather than there's something else going on. And wet nappies always gives us an idea of how unwell the child is. If they're not peeing and pooing as they normally should, then we should be worried. And again, fever, weight loss, and irritability, so kind of just like their behavior and how they've been. Past medical history, just ask generally about their medical conditions, anything that they've been diagnosed with since birth, any surgeries that they've had, and then the rest of the past medical history. The way I like to think about it is during the pregnancy, during birth, and then up to the point of them sitting in the consultation room with us today. So prenatal, if they've had any complications or any problems with the pregnancy, if they've had any tests, any abnormal results on any antenatal screening tests, and then birth complications. So ask about how they were born, if it was natural, cesarean, any like their gestational age, and then their birth weight, and any sort of admission or specialist input into their care since they've been born. And then up to this point, just ask about if they're meeting their developmental milestones, and if they've been, the parent has been plotting their growth on the growth chart, and if there has been any problems with that or any worries about that. Next slide, please. So drug history, again, your usual, ask about allergies and what type of reaction they get. And ask about any medications that they take, including over-the-counter, any inhalers, but always remember to ask about vaccinations if they're up to date, and if not, ask why. Because, you know, if they say no, it could be that the mom or the parents are not, are like against certain immunization, and that could be the focus of the history, really, or of the station. And then I forgot to put in family history, but just ask, is there any medical condition that runs in the family, or anyone at home that's unwell, sibling, or just if we're thinking there might be any sort of infective like problem going on. And then taking a social history is really, really important, just because to kind of gather an idea of how things are at home, depending on the different stations that you might get. Some things might be down to a social or a psychosocial cause rather than an organic cause, which is what we're going to go on to next. But basically, just ask who's at home with the child. Do they have any siblings, any pets at home? Where do they live? Just kind of to get an idea of like the economical situation at home. If they go to school, ask if they have any friends, any hobbies, things like that. Obviously, for the sake of time, try and tailor what to ask in this situation or not. if it's, again, if the focus of the history is a social history, then spend more time on this. And then social services, an awkward question, but the way to normalize it is just say a question that we ask everyone: have social services ever been involved in the care of your child, kind of thing. And then remember to ask if the child, it depends on the age, obviously. You won't ask a 2-year-old if they smoke or drink alcohol or do drugs. But yeah, older age, you definitely ask. But I remember to ask if there are any smokers at home, just if they're coming in with wheeze or any sort of respiratory problems. And then heads, I didn't go into too much detail about on heads just because for the sake of time, but I would recommend to go and read up on heads. That applies more for adolescents and teenagers. But yeah, for the sake of time, I won't be able to go through that today. Next slide, please. So that was kind of the general structure you can use with any presenting, like your typical presenting complaint that you might get. So vomiting, changes in like respiratory problems, anything like that, you can apply the general structure. But I thought failure to thrive is a station that kind of, if they're coming in saying my child is not growing as they normally would, it's kind of hard to know where to begin from, where to start, kind of. So you would need to try and dig for the cause and figure out what's been going on. And the general way to do it is a good review of systems. So literally just go through different systems and ask, any pain, any breathing problems, any, fevers, have they been themselves, exactly what we were just talking about. But also with failure to thrive, there could be a more psychosocial side of things that could be causing this. So again, like I said, go through the entire history, so pregnancy, birth, development, and social history. Ask about eating and if they're latching okay. Maybe ask about food diary if we think it's a problem with them not eating well. But also ask about mom and dad and who's at home in general, who looks after the child. Just kind of try and pick up if there's any sort of neglect or any just abuse happening at home. So that's why social history is really, really important in this station. And then the way you would figure out if someone is failing to thrive, it would be through plotting, obviously, the weight, height, and BMI. They might get you this to do in the station, although an easier thing to do is to have a parent coming in with that plotted, and you will see that they are not growing as fast as they should be. But the way to figure out or establish that they are actually failing to thrive would be through the mid-parental height centile. So as you can see on the right here, it would be through plotting the mom's and the dad's height, and then the mid-parental centile. If it's less than 2 centiles below the mid-parental centile, then that's failing to thrive. And a centile, just for those of you who don't know, a centile is basically the distance between, let's say, the 50th to the 75th. That distance is 1 centile. So if it's below by 2 of that distance, then they're failing to thrive. Or if you plot their BMI on the BMI chart and they're below the 2nd centile, that's also failing to thrive. Just kind of, so maybe they might ask you to plot it, but if not, and you are presented with the symptoms, with the growth chart, this is just kind of to know how to read it. Next slide, please. So in terms of the causes of failure to thrive, you could split it into organic causes and non-organic causes. Organic causes could be things like them not eating properly, for whatever reasons. We'll go to talk about organic causes a bit later. Problems with absorption or increased sort of energy needs, so they're not eating or not intaking as much food as their body needs. Non-organic causes, that's where psychosocial or environmental factors come into play. So that's where a social history is very important, or like to take a good social history. So just asking about, what they eat in a day. Don't make it awkward, just say, talk me through what you eat in a day, just kind of to get an idea of, do they have the sort of the the money to be able to eat? Or is there a problem with, the family not being able to supply, that kind of thing? And then it could also be lack of knowledge. So they snack a lot and don't have a proper mealtime structure. Or poor feeding techniques. It could literally be that the mom is not able to feed the child because she hasn't had much, practice with latching and things. So that all will kind of determine how you approach the problem. And then things like child abuse or neglect. So if the mom is not paying much attention, or if they're not involved in their care as much, that could be one of the causes, or just abuse. So you could, in this case, ask the child, obviously taking the mom outside, or just ask her to speak to the child on their own, ask the question sensitively, obviously. Next slide, please. So in terms of organic cause, like I said, we can break it down into they're not eating well, they're not absorbing what they're eating, or they need more than they're taking in. So in terms of not eating well, it could be just things like developmental delays or learning disabilities, any problems with their palate or the mouth, so cleft lip or palate. Might not allow them to suck on the bottle or the breast, or eating disorders, but that's further down the line if we're thinking teenagers or adolescents. And then nutrients problems with absorbing what they're eating, so things like celiac, IBD, cystic fibrosis, GORD, milk protein allergy. So all of these conditions, remember to ask the relevant questions. So vomiting, stool, any pain in their tummy, just kind of run your head through a review of systems and think every system, what could be causing this, and ask the relevant questions. And then increased metabolic demands. With these, it can be a bit tricky. Just kind of ask, has there been any specialists involved in their care? Obviously, you can explore some symptoms and things like that. I just don't know how you would be able to spot renal disease or like renal tubular acidosis through history. So again, past medical history, any conditions that they're diagnosed with, any infections. So you could ask about at home, anyone been unwell, etc., that kind of thing. Next slide, please. So in terms of just addressing the cause, so once you figure out what's been going on, hopefully you do, it would be to treat the cause, so whatever is causing it. If you think they have celiac, you would give them the plan as you would for any celiac patient. So avoid gluten, we'll do X amount of tests on them, and then follow up, that kind of thing. GORD, Gaviscon, if they have any breastfeeding difficulties, so support from the midwives for mom to show her how to breastfeed. If it's mental health that we're worried about, we would provide support for the mom because it could be neglect, as mentioned earlier. And then arrange for annual follow-ups to monitor the growth. So just kind of to make sure that once we address the problem, they're growing as they normally should. And then encouraging mealtime and healthy sort of snacks rather than their entire diet is them purely snacking. MDT approach, so always say, Bristol love saying MDT approach, so always say I would refer them to this, or ask for this specialties input. Just always remember to mention something in any station in general where applicable. Remember to mention MDT. So in this case, we would say refer them to a dietitian just to come up with a good diet plan to kind of help them catch up. And then what they might need is additional energy dense foods, so things high in calories to make them basically catch up with, not catch up, but kind of speed up their growth. Because one question that you might get at the end of the station is, will my child be shorter or smaller than their peers that are at their age? So as long as we address these, address the problems and make sure they get good source of good energy levels from their food, then hopefully they should catch up and should not be a problem that they're smaller than their peers. But yeah, next slide. Lovely. That's all from me. Thank you very much. But yeah, if you guys enjoyed this. I hope you give us a like and send us any messages on any stations that you think might be useful in the future in general. But yeah.
Yeah, thank you very much for that, team. So yeah, QR code there. I've just linked the chat as well with the How to OSCEs site, so definitely check that out. There's a feedback form QR code there as well. It's also in the chat.